Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends podcast. The podcast is designed to help you feel, see, and think differently about the podiatry profession. With me today is Dr. Tea Nguyen, and Tea was on a previous episode way back in episode 38, and it was life changes and practice ownership. And I think there's been a lot of life changes with Tea recently. She is a surgical podiatrist and a solo practice owner in Santa Cruz, California, which everybody knows where it is because we all watch American TV. So, Dr. T, how are you doing today?
Hi, Tyson. I'm so excited to talk with you again. It's been, I feel like forever. I feel like I've just been constantly reinventing myself, and it's like a whole new decade now. But I know it's only been 2 years probably.
I can't remember the exact date when episode 38 came out, but the podcast has been going now over 3 years. So I would say it was in the first. It was definitely in the first year. So we've probably been spoken for a couple of years, but I see you on Facebook all the time and you see me on Facebook and we're always commenting on what each other are doing. So I feel like, it doesn't feel like it's been a long time since we've chatted.
Right. You're in my life every day, Tyson.
Isn't it amazing about social media? It's a little bit like that. I've got a friend that was on a recent episode, Dr. Brent Seaver. And we were talking about, it was last week's episode. We were talking about building up relationships with professional referrers. And Brent was a professional referrer in Cairns that I met. And then we became friends. And now we've been friends for well over 2 decades. And there was a period of time there, I think we worked, it was like 11 or 13 years that we hadn't spoken. But because of social media, we were sort of in each other's life. And then when we caught up, bang, we just started talking for him. So if I'm ever in Santa Cruz, we will catch up for a coffee.
That sounds great. Yes.
So what have you been up to? What I know today, there's 2 things we're going to be talking about. One is mentorship for female podiatrists or DPMs in the States. And the other thing you wanted to talk about was direct care. So first, let's get on to, I want to talk about the direct care. What do you mean by direct care? Because I know American system, Australian system, UK system is a little bit different.
Yeah, so I only know the American system, right? We have privatized health insurance. We have the government version, and then we have private companies. And so a lot of the way we treat patients is heavily dependent on insurance reimbursement. So it's kind of like you're sick, then you see the doctor care.
Yeah.
And now that's predominantly what new grads are going into. They want to be employed. They want to have that business side of things taken care of for them. And they just want to show up to work, get a paycheck, and go home. So that sounds really dreamy, right? And now we're getting to the point where physicians don't have a lot of control in the way that they practice medicine. It's all regulated by administrators, by people who are watching the dollars come in and leave. And so doctors are now getting burnt out significantly in the US. A lot of people are looking to exit or get a side gig or just find other means to make money without the stress. So direct care is just practicing medicine. It's a different way to practice medicine. We don't rely on insurance payment, but I think this model has been in existence probably all over the world because it's like any other service industry. You go to the grocery store, you want something, you see the price, and you decide if you want to buy it or not.
Yeah.
You don't go to the cashier and negotiate, well, I really only want to pay $2, although your price says $6. We don't do that in any other service industry except for in our healthcare. And it's been kind of a spider web of an experience when I had opened my primary practice in 2018 as insurance-based. And just waiting for that payment to roll in. They promise payments in 30 days or 60 days, but I've gotten payments 12 months after the fact.
Jesus.
And I just couldn't imagine telling my staff, listen, I can't pay you every 2 weeks anymore because the payments never came, or it's going to come in 9 months or whatever it is. So that was just the most inefficient way to run a solo practice in my experience. And so now I've learned about direct care, which is very similar to concierge medicine, where we're just trying to rely less on the insurance reimbursement.
So what I like about what you're talking about, now there might be people in the UK and Australia, New Zealand who are listening to this and thinking, that doesn't happen in Australia. But I've been watching this in the United States for well over 20 years of what has been going on over there. And I've seen the struggle that podiatrists have had where they have to have these agreements with hospitals, insurance companies. And if you don't have it, you don't get those patients, you don't get paid, and it's really tough. And I have noticed a big shift where they've wanted to do direct care, where we'll just treat you. This is what an orthotic costs. If you want to get orthotics from me, this is what it actually costs. In Australia, though, we are more of a direct care base profession. However, I have seen the changes where the government has started getting involved in different areas, and there are some practices that are very heavily swayed towards living off of patients that have government cover, not so much the insurance companies, but there are podiatrists that do have agreements then with different insurance companies that, and they agree, well, the insurance company tells them what they will charge the patient. And if they do anything different, and I've seen that over the years, and I started to get really concerned that we were going to head down the same path as America. But fortunately, it has not happened.
I'll tell you, a lot of doctors get really rich off of insurance reimbursements. Like there are pockets in medicine where you can make it work to your advantage.
Yeah.
And podiatry was there for a little while until they started recognizing the utilization that podiatrists was having and started to be more restrictive about what was being delivered. Orthotic coverage, for example, diabetic foot care, there became more and more limitations as time progressed. So not only is our administrative burdens increasing, our stress is increasing, and reimbursement continues to, Medicare has not increased reimbursement rates for like 20 something years now.
Yeah.
And it continues to go down. And this year they just announced another cut in reimbursement. So it's like, at what point can we envision our practice future and say enough is enough? When do we finally opt out? For me, that was 2 years ago.
Okay, so over the last 2 years, or 2 years ago when you made that decision, have you slowly just not relied on the insurance companies as much and have started promoting yourself more to the patients that your direct care, that podiatrists, that you don't need health insurance to come and see you? Is that how you've started to make the change?
Yeah, 2 years ago, I made the conscious decision that I'm going to do something different, that I'm not going to rely on insurance reimbursement. So it was just an idea at the time.
Yeah.
So I started talking to other people who had a cash practice or a direct care practice. So direct care is more of a social movement, but ultimately the umbrella is a cash practice, right? Less insurance dependency. So I started to talk to other specialists outside of podiatry who have cash practices that are thriving. And I asked how it was working for them. And they all said the same. You want to transition out because at the time my revenue was 90% dependent on reimbursement.
Yeah.
So my marketing effort was dependent on being within the insurance contracts. So now that I had to switch out of insurance and more towards the cash practice, it was a transition. I slowly started opting out of the worst payers first, and then started to feel what that experience was like. And that was, that was a significant change that I had to plan for in the next 1 to 2 years, and I'm still going through.
When you say worst payers, are you talking about worst, the insurance companies, which were the worst companies to basically work with, and you slowly got rid of them and worked your way through it?
The worst payer mean they paid me the least, but demanded the most administrative burden. So we had to go through prior authorization. I had to hire extra staff to be very specific in that insurance just to catch the money that is already owed for the services. Mm-hmm.
I remember going to a practice in Denver, Colorado about 6 or 7 years ago, and went in the beautiful practice, gorgeous practice. Went in there and they had the reception, and they're explaining, oh, this is how we've got everything set up. And they said, oh, this area here, this is where the two ladies sit who take care of billing. And I went, what do you mean billing? They said, oh, I have 2 people employed purely just to deal with the insurance companies to try and get payments. And I said, so what percentage do you normally get back? And they were saying, oh, if we can get 60% of what we charge back, then we're doing good. And that's why I wanted you to get on here, even though I know people in other countries might listen to this and think this doesn't apply to us. But to me, we need to be aware of this, because if we let the insurance companies start telling us what to do, if we let the government start telling us what to do, when it comes to what we're worth, then we could end up down the same path. And watching what happens in America, once you're down that path, it's really hard to turn around and come back again.
Oh my gosh, if you're listening and you're not in the insurance-based practice, but are thinking about it because you're in a different country, it's coming to your place.
Yeah.
Let me tell you, a lot of us are opting out for a good reason. We're, the benefit of opting out, I can list 100 reasons, but the top 3 reasons I tell my patients, the reason I'm opting out now is because I want to spend more time with patients.
Yeah.
When you're insurance bound, your time is limited because you have to see volume. You have to see a lot of patients to make up your revenue. Number 2, price transparency. Patients get really pissed off when their bill comes 9 months later. Like, they were prepared to pay that day they saw you.
Oh, yeah.
But when the bill comes 9 months later, maybe they lost a job, maybe they lost their source of income. It's just a big surprise and a big level of agitation that I didn't want my patients to experience. So price transparency, we don't have a clue of what things cost now, but when I have direct care practice, it's all listed on my website, and there's really no argument about the price. It's either you want to pay for it or you don't. And then, we can certainly work out payment plans if it's like out of budget or whatever. So that was a big deal for me. And then lastly, just not letting somebody else interfere with the patient-physician relationship. If I want to order an MRI, I don't want to have to ask 3 different people that I want the MRI and then be told, well, why do you want the MRI? Did you send your chart notes? Have the peer-to-peer call with another specialist who's not in your specialty, perhaps. And so it's like, it's mind-blowing how much is in the way of taking care of patients.
So, and you've got a podcast now that you're talking about direct care billing.
So I have a podcast called The Direct Care Way, and it's really aimed towards podiatrists looking to pivot out of insurance-based practice into a direct care model. And you can have variations. You can have a hybrid, or you can be 100% direct care. But it's not about the billing. It's about a lifestyle, and it's about the movement to securing the patient-physician relationship. And it's really just my story on how I went from understanding only the insurance-based practice to how it transformed into a direct care practice and all the benefits that come in between. On top of that, there are some business skills that we never were taught anywhere in our education that I learned along the way that is just as valuable as getting an MBA. But you don't need the MBA. You don't need an extra 6-figure debt to learn these skills to adapt a direct care practice. So the point is, it's digestible material within 15 to 20 minutes just to get people thinking about a different way to practice.
So with, like in America, for example, just want to go back to the insurance companies, what percentage of your patients have insurance compared to those that don't have insurance?
Currently, my direct care practice, I have like my reimbursement rate from cash is 90% now. Whereas when I first started, it was majority insurance-based. And in my community where I had my practice, where I have my practice, median household income is $35,000. So they're low income. Yeah. They're farmers. They're people who are seasonal, so they have insurance for a short period anyway. And so it's not like you have to cater to rich people as it's once perceived, the way concierge medicine is. It's really for anyone who just wants quicker access to their doctor and they don't want the restriction of their insurance.
Okay, so when somebody walks into your practice, do you actually ask them, do you have insurance, or do you not worry about that anymore?
I still ask because that's the culture. People expect their insurance. So I've instructed my staff to just let them know we're not contracted with insurance off the bat, and then let the patients decide, do they want to continue the conversation? Because oftentimes they'll be on the phone for 10 minutes with the assumption on both sides, our side thinking they called because we're not insurance based, and the other side thinking that we will bill insurance. And so then, you're wasting a whole bunch of time having this conversation because everyone assumed, oh, I thought you billed so-and-so without having to inquire about it. So we do have to break the culture when people call. And so I'm having to rely a lot on my current patient base to refer to our practice because they're the ones that's saying, oh, by the way, they don't bill insurance.
Yeah. So with your podcast that you created, the idea with that is to share part of your story on how you went from being very heavily insurance based to moving more into direct care or cash based.
yeah, it's like, it's really the discovery of direct care, the process I've been going through in the last 2 years. I'm just finishing out another contract, which will be the end of it. So I'm kind of like the hybrid where I do bill insurance, but it's like against my will almost. And then I'm going to go straight cash and just call it a day and
Yeah.
just be done with all that.
So that's it. And then you'll eventually just be 100% direct care, cash-based. But see, over here in Australia, when you hear the word cash-based, it means money under the table, bit of
Oh,
slipping.
so is it like a bad like
No.
connotation?
It's just usually when someone says, "Oh, we're just a cash business," everyone goes, "Oh." See, in Australia, if you're a patient, you come and see me and say the bill was $150, you will pay your $150 to me on the day, and you walk out. No accounts, just don't worry about it. So I could look at how much was owed to me at the end of any year, and it would be zero because I didn't really work with government departments. Patients paid up front. We didn't give out accounts. And it was a great way of running your business because you knew financially where you were at any single point in time, not what money was actually owed to you.
This is the conversation that I wish I would have had in residency training.
Yeah.
But because our residency programs, they're funded by insurance governments, that's why we have certain spots for certain programs, then we only know how to practice insurance-based. So then we're missing a complete population of people who choose to not have insurance or want to pay cash, or they want innovative care that's not even covered by insurance, or this, and that. So we're actually leaving out a big population of people who want to pay cash.
Yeah.
And we never were taught to have that conversation.
Yeah. And the funny part is in Australia, well, I remember being on this bus with a group of podiatrists. This is when we were in Denver. And I put my hand in my pocket. And I had my wallet in my bag, and I pulled out my health fund card, which is the one that was linked to my insurance company. And I said, "See this card here?" And it just looked like a credit card. And I went, "Yeah." I said, "So I will go and see a physiotherapist, for example. They'll tell me what the fee is. I give them this card. They swipe it through. They get paid by the insurance company that day." I said, "And I just pay the balance." And that's how it works. There is no chasing insurance companies. And they just went, so that little card that you have is all you need. I said, "That's all I need." If I go into hospital for a procedure, I go to the hospital, all they want is my insurance card. They take care of it all. It's all paid for. They get it straight away. And it's done. So, and they were just amazed at why the system in America was so different. But the other part that's really weird with America, which I find strange, it's got nothing to do with podiatry. This is just weird in general, is you guys still accept checks. People still use checks. Can I write you a check? Over in Australia, I haven't seen a check in years. But in America, it still seems to be a common thing. Do you have a checkbook?
I have a checkbook. I don't use it, but my patients do. Older people who are just not into tech stuff, or they need to keep better track. Checks are nice because you don't have a processing fee the way you do with credit cards. So I still welcome check. It's equivalent to cash.
No, I remember because I was over there a few years ago as well, and I had some of my books there. So I said, "Oh, can I buy one of your books from you?" I said, "Yeah, no problem." And they pull out their checkbook and they start writing a check. I said, "What are you doing?" They said, "Oh, just writing a check." I said, "Don't write me a check." I said, "What am I supposed to do with it?" I said, "Give me cash or buy me a couple of drinks at the bar when we go down there later on." So that's what they did. So it's funny how our systems are different yet similar in so many ways as well.
You know, the biggest problem I have, okay, so we know insurance is important for catastrophic events. Like you can't predict when you're going to get into a car accident, so you're going to need that coverage. Perfect. But now that insurance is kind of accessible to everybody everywhere, it's being abused or overutilized, or people are kind of scheming the system to get reimbursed more. And so that's why we have all these hyperinflated costs. So that's like true. The surgery I would do at a hospital would be 2 to 3 times more than what I would charge for cash in my office. And I just feel like there's this whole unethical process that we're not really digesting. Like we're not really asking those questions. Like what does it really cost the patient? Because in the US, the number one reason for bankruptcy is still the cost of medical care. And although we provide a lot of highly innovative medical skills and things like that, it just blows my mind that people are going bankrupt because of the access to healthcare is just too costly.
Oh, we hear about that.
And you guys know about our problems
Oh
probably.
no, but we are told
Oh,
if you're ever traveling to the United States, we're almost, when you buy your ticket on the plane, you're almost given a T-shirt that says have insurance, have travel insurance before you go. You do not want to get injured or have anything go wrong with you in the United States, because you will lose your home. Otherwise, it will cost you that
but
much.
if you do, you can look for a direct care practice, because specialists are learning about direct care like myself, and we can offer a better rate than the insurance can. So that's growing. I anticipate this to be a massive change in the next 10, 20 years. Of course, it's not going to be overnight, but it's there depending on where you are.
Is this because you're changing, like say a bunion procedure, for example, someone needs a bunion operation. Previously, would you have done that operation in a hospital, and therefore the costs are sky high?
Exactly.
Now, do you do have you set your office up that the procedure is done in your office in your own like surgical center?
Correct. So my access in my community is a hospital or a surgery center.
Yeah.
And the hospital in itself is just expensive. It's just what it is. So not knowing, obviously early in my career, not knowing the price difference to the patient, I was really blinded to what the patient was paying out of pocket until they told me after the fact, because they had a deductible to meet and this, or that. It was very confusing. So when it was brought to light, from a patient saying the surgery at the hospital was very expensive versus what I offered in the clinic, then it made me really evaluate how I was even offering treatments to patients. So now I, of course, do the surgery in my office. Cost is like more than half. And the care is a little bit higher because it's just me and the patient. I don't have to pay 10 different people in between to get the service done.
Yeah. I don't think anyone's surprised when you've got to go to hospital for anything that it's going to cost money. Over here in Australia, we have like the private system and public system. If I blow my knee out, for example, see an orthopedic surgeon, I would go through, say, the private system. Even with insurance, I know it's still going to cost me a certain amount of money. However, I can go through a public hospital. I might have to wait 2 years, but I can still get the operation done and it costs me nothing. It's free.
Mm-hmm. Mm-hmm.
So a lot of people put up with if they don't have money, they'll put up with the pain and wait years for an operation, or you have the money and you go privately. So good part is it's not like it is in the United States.
I mean, there's good and bad. You definitely have the benefit of both on each. There's no one perfect system, which is the idea of the podcast, is to really just demonstrate what's possible. I was stressed out in the insurance-based model. I did not do trauma care, so that's all that is kind of irrelevant to me having insurance-based practice. I thought I wanted to, which was kind of an error of judgment when I left my residency program, because I was trained to do these trauma cases, but it didn't mean that I really wanted to do them or should do them. But aside from those catastrophic events, like most of podiatry is elective. And we can actually give better care if we're just charging the patient directly, because when patients put skin in the game, they're a little bit more responsible for their own care. They're going to make sure that their dollars are well spent. And so I have a bigger obligation to ensure a better result in those scenarios.
Yeah, no, it makes perfect sense. So is this what led you on to the other thing we were going to talk about, is doing mentoring now for young female DPMs?
Yeah, well, a couple of things. I almost got kicked out of my residency program. I don't know if I shared that with you in the past, but I had a terrible time in my training.
Yeah.
It's still considered male dominated. At least the culture is, even though within podiatry, we're getting closer to the 50-50 ratio of female to male. But the culture, the backbone of it is very masculine energy. And so when I was going through my residency program, I had a lot of hardships, and I didn't really have anyone to talk to or to share things about that was very specific to being a female surgeon. So along the road, even through fellowship and through my practice, I had really wished I had just that one resource to help me see the bigger picture, because I was so consumed in the details and all of the knowing of things.
Yeah.
That I was like, you know what, I am a step ahead of many people that I can help. So even if I'm not the expert at the one thing, I can still help somebody 5 years behind me. And I think that's just as valuable as someone who's 20 years ahead of me. So, and plus I'm so fresh that I can share those stories And it's a much more relevant than maybe a story from 30 years ago, for instance. So I do have a pocket of opportunity to help somebody who wants to transition either directly into direct care or private practice in some manner, or they're pivoting from insurance based. And, I can share with them the good things and the bad things and the mistakes I've made and maybe help prevent it for other people.
Well, I think if more people in the profession gave back to the younger ones that are coming through, the profession would be so much better off. I think what happens is, like you said, you haven't been practicing for, say, that many years. So therefore, all the wounds are still quite fresh. Whereas if I think back to myself, being out 33 years or something like that, you think back to your first 5 years and the scars are still there, but the wounds aren't fresh. So it is a little different.
Marketing in itself is evolving, and we're so afraid as doctors to learn about marketing because we feel that it's sleazy. It's as if we're trying to sell people something they don't want. But marketing from 10, 20 years ago, which was hang a shingle, they will come, that doesn't work anymore today, in this day and age. And so even that in itself evolves. And I think it's important to be able to connect with somebody who understands that market and share that with others.
I think people think when someone needs, say, an orthotic, for example, you have to sell them the orthotic. The orthotic is a solution to a problem. So podiatrists really just go think, all we are problem solvers. So if someone has a problem, you have a solution, you put the two together. If they don't want to follow your solution, then they don't follow it. To me, you're not trying to ram some form of treatment down somebody's throat. And if you're doing that way, and if you feel you're doing that, then you're doing it the wrong way.
And I'll tell you, in the insurance-based model, because their reimbursements could be so poor, people push for things that maybe patients don't necessarily need. They don't necessarily need because insurance pays for it. So when you start thinking of that mentality, well, insurance will pay for it, then your treatment is reliant or dependent on what the insurance will pay for. So that is orthotics and that is surgery. Insurance does not pay for palliative care. A lot of physical therapists have a hard time having insurance reimburse them. And they had it right in the first place. I follow a lot of the physical therapists and chiropractic models out here. A lot of them don't even take insurance anymore. And it's like, now I know why. So that's the model I want to follow.
Yeah, I think people think, rephrase that. I think a lot of people think, I keep stuffing that part up. See, that's what I said, this will be in the video, but I'll edit this out of the podcast. I lost my didn't lose my train of thought. I'm trying to word what I was going to say. I think when it comes to insurance companies, a lot of health practitioners think it's great to be part of using the insurance. But I think it's a really good point what you just pointed out, that when you know an insurance company is going to cover certain things and you feel like you may not be getting paid what you're worth in one area, you may be sort of influenced to charge for these other things that they may or may not actually need, so that you get paid what you're actually worth. And that can sort of spiral out of control as well.
Yeah, and then it's just creative billing, and that's why there are all these seminars on how to bill. And now when I get those emails, it can go straight in the trash because I don't care.
Well, I think the other part too, if you're doing creative billing and it's borderline, I'm not saying they're committing fraud, but if you're doing very creative billing to get more money back, what are you also teaching your team? Because if they're looking at it thinking, that's borderline not right, then are you teaching them, hey, it's okay to break the rules? So will they then in turn do that to you? Yeah. Will they break the rules on you when you're not watching exactly, because that's what you're teaching them to do?
This is so important because that's how people get caught up in the money. You think about the money, you're not thinking of the outcome. True. And that's a huge problem. So when people, I get this all the time. I get patients who, from a retired podiatrist, come to see me and they say, well, my other podiatrist got this paid. Why can't you get it paid? You must be coding wrong. You must be blah, blah, blah. And it's like, well, do you want me to call out that doctor and say that was fraudulent? Or do you want me just to move on and like try to help you today?
I know.
So patients feel very empowered to tell doctors what to do these days. And I just took that out of the equation. I said, I just don't bill. This is my price. You can take it or leave it. And it's so much easier.
Yeah, I had a patient once who said, "Oh, I know I'm only covered one pair of orthotics per year. Haven't had a couple for a few years." And I said, "Yeah, that's correct. One pair. So if you want to get a second pair," I said, "we can do it at a reduced rate if we make it at the same time." She went, "Well, what my last podiatrist did for me, we've got me a second pair, but put it under my husband's name. Would you be able to do that?" And I went, "Am I prepared to go to jail for you?" No. I said, that's the simple answer. And she told me who a
Yeah.
podiatrist was. And I just went, my God. So I actually rang that podiatrist. So I knew him pretty well. And they were working for somebody else. So I rang them up, and I won't say the name. And I went, "What's the story here? This patient." And he went, "No, I remember that patient because they were from, say, Cairns. I only did one pair for them." I said, "Go and look in their file." So they went and looked at the file, and a second pair was made, but it was the owner of the practice had called up the patient and said, "Hey, we can do a second pair for you. We can just put it under your husband's name." So so all of a sudden, the guy that I knew is going, "This is just so wrong." And he approached the boss, and they went, "Oh no, that was a clerical error. The receptionist did it." And
Sure.
he left pretty quickly from that particular business.
Yeah, and it just takes the one incident for you to like get tied up with that, and then
Yeah,
I don't know. That's like a lot of like mental space I don't want to occupy. I don't
money's
want to
not
think
worth it.
about how to bill, and then at the end of the day, you get caught. And how
Yeah,
much money do you owe back when you get caught? And this is happening with those amniotic injections. There was a big period of time where podiatrists were offering amniotic injections. We're told by sales reps the Q code on how to get insurance to pay back, and they were getting a generous amount. And then guess what? They retracted and said, "Well, we decided that we're just going to take our money back."
yeah.
And that's like thousands on thousands of dollars that you probably don't have in a practice. You can't really afford to lose. So it's almost like to your benefit to tell them off the bat, it may not be covered by insurance. I'm going to collect the full amount if you want the treatment.
Yeah, I just think I think anyone who's listening to this, when it comes to running your practice, is just be ethical on all levels. Just do the right thing. I had a friend of my parents who was an older guy, and this is before I even started university. And I remember him pulling me aside and just saying, and he was a really, really wealthy guy. And he said to me, "If you just do the right thing when it comes to work, your career, whatever it is you do, just do the right thing, especially when it comes to money." He said, "You will go to sleep at night and never have a worry in the world."
I want to share a story with you real quick.
Yeah.
So I was subleasing an office space to another podiatrist. She had the assumption that I would serve as her offload, someone to do the nail care for her patients because she had stopped seeing a certain number of patients under
Yeah.
Medicare. And I had told her, "Well, the patient doesn't meet criteria. This is my cash price." Then she got mad at me. She goes, "How can you charge these people for your service?" And I said, "Because it's ethical. Because it's because it's not covered." Like I didn't want to have this confrontation with her, but it was just that mentality. Like they have insurance, you should use it, versus what I felt was right. I did not feel it was right because they didn't have qualifying criteria. And then now I look like the bad guy telling the patient it's not covered. And now I look like a criminal trying to ask money for my services. Like it blew my mind. So no, I'm not doing that anymore.
No, I just think it's just do the right thing, and you'll just sleep. You'll sleep well at night, and you won't feel. Oh, I've had some podiatrists say to me, "Oh, I did such and such, and I feel really guilty for doing it." And I'm going, "Well, don't do it. If you feel guilt when you do something, then obviously it's messing with a
It's a
value
gun.
or a belief somewhere. Then don't do it."
Yeah.
It's really, really simple. So if people want to learn more, you've got a website, DPM dot CARRD.co.
Oh, card. Okay. Yeah. Yeah. So tea.carrd.co. That is my female to female mentorship page.
Yeah.
So if people want to connect with me, just ask me quick questions about direct care. I would love to connect with other podiatrists. In that link, there is also the podcast, The Direct Care Way. I'm on episode 6. I've had 100 downloads. I'm so excited.
Yeah.
It's like the beginning stages of things, and you're like, I'm watching my baby grow. Because I believe that this is going to be the ticket to freedom for a lot of us who are just, really fed up with the traditional system. And it's just a nice way to know there's other ways to do it, to do medicine.
Yeah, we'll keep pushing the podcast. There's this thing called I don't know if I've mentioned on this podcast before, called pod fading. And something like 93% of podcasts never get past 9 episodes.
Oh,
93%. It's massive, a massive amount of.
That's a good number. Okay, I got a goal now. Great.
You
So
must
what's
go,
it
yeah,
called?
because pod fading, yeah, is you get to 9 or 10 episodes and all of a sudden it just drops off, because people don't realize how much work is involved on doing a podcast. It's not just 2 microphones, we get together, have a bit of a chat, and that's it. There's a lot of work that goes behind the scenes that people don't see, whether it's editing, promoting, organizing guests. Fortunately, I'm just at that point now where I don't know, almost 200. So 200 on this podcast, and if anyone wants to go and check out It's No Secret with Dr. T, which was my other podcast, I did 211 episodes on that one. So I am definitely not a pod fader, and you will not be a pod fader either, Tia. You will
it took me,
keep going.
so I have like over 100 like personal recording on my iPhone, like voice, and I'm like, oh, that would be a great topic. So
Yeah.
so I have all these recordings. So in my treasure chest, I have at least 100 to go.
Good.
So I'm hoping I make it past that 10.
Yeah, just keep putting them out there. And I think the idea with whether it's podcasting, insurance, whatever it is that you're going to do, consistency is the key. It's just create habits of consistency. That's the important part.
I've learned a lot of marketing stuff from you, from everyone that's
good.
gone through. Yeah, because it's like no one's taught me this stuff, or you just do it and you learn. And you're like, well, isn't there a shortcut to all of this? So yeah, consistency, and just the metrics that we use, the likes and the vanity metrics, like that doesn't really give us the results. And I think I didn't know that early on. So like if I put something out and I didn't get a like, it would be very discouraging.
Yeah.
But keeping on the motion and just pushing stuff out until people just get sick of you. I think that's like marketing, like solid marketing is how you should do it.
Yeah, I think with all marketing, a friend of mine, just said with all marketing you do, your whole goal with marketing is to attract and repel. So you'll put something out there and you're trying to attract the right people and you're trying to repel other people, but always doing it in a respectful way. You're not being rude or disrespectful. It's just you put your message out there and there's going to be a certain group of people that'll go, no, it's not for me. It'll be like your podcast.
That's exactly right. Yes.
You will say, hey, I do mentorship for young female DPMs. There'll be a group there that go, oh, Tia, you are wonderful. I want to talk to you. And there'll be another group of young DPMs will go, why would I even ask for help? I don't need help. So you just keep doing what you're doing. You'll attract the right people. I repel a lot of people.
I piss off lots of people for not taking insurance. They're like, how dare you? I'm like, how dare you not to pay me? Like, come on now. So it's great. It's been a great move. I attract more of my people that I can actually help. That's
fantastic. So have you got a final tip before we finish up? I just want to let people know too, you are on Facebook. Just look for Tea Nguyen, which is Nguyen DPM, and the same on LinkedIn. So track you down there, stalk you at night while you're sleeping if they want. So have you got a final tip before we wrap up?
Yeah, final tip is whatever seems hard but you want to do, you can learn this skill. Like I didn't learn any business skills. I didn't go to MBA school. You're only a skill away from getting what you actually want. So just keep that in mind. There's a lot of people out there that are willing to discourage you in your path.
Yeah.
Go ahead and let them exit.
That is a great tip to, tell them to bugger off.
Go bye.
So Tia, I want to thank you for being on Podiatry Legends podcast again. And I'm sure we will talk again very soon.
Oh, thank you so much, Tyson. Have a good one.
Just end the recording there and hang on, it's going to end the video now. So if people are still watching the video, I will be chatting with Tia in a sec. Hang on. No, it's going to find the button to press stop. There we go.